Go ahead and get started. We'd like to welcome Maria Ferris, who's here from University of North Carolina, and please, everybody be kind. I know we just got trounced by them, but she has nothing to do with that. And she's the director of the Pediatric Renal Transplant Program and Dialysis Clinic at UNC Chapel Hill. She is the founder of the UNC Transition Program, which has been in effect since 2006, and the purpose of that program is to help to ease the transition of adults coming into kidney care that develop their kidney disease as children. And so, since I'm probably more nervous than she is, I'm going to go ahead and let you get started.
Very good. Thank you so much. Thank you very much for having me. Good afternoon. It truly is an honor to come and share the work that we've done and what we are learning so far. And I love the interdisciplinary audience because that's exactly what needs to happen when you are trying to create a transition program. This is not just a physician or a nursing program. It's everybody's program. My topics today, before I go there, I want to thank Tejas Chai and Dr. Hidalgo for inviting me to be here. The topics I will discuss, we're going to talk about adolescents with chronic health conditions. Then I'm going to show you some of the data, early data, that justified our existence in our program. I call it the 360-degree perspective on transition. We asked all players several questions. Then we're going to talk about adolescents' comorbidities and their cognition. And then lastly, I'm going to talk about the tools that we've developed with the help of an interdisciplinary team, and share some of our preliminary data. Before I continue, I like to start my talks by my thank you slides, because everybody seems to rush when they're doing the presentation, and at the end, oh, and these people help me. And I actually like to honor the people that help me. You will see in this slide that I collaborate with several programs, several subspecialties of pediatrics. If IT, I would not be able to do what I'm doing without the help of the IT folks. And then people in other institutions, such as yours, Tejas, Guillermo, and Chai, who are becoming strong collaborators. We do collaborate with Duke, believe it or not, and we do collaborate with a healthcare transition consortium, which is an international group of researchers that do work on healthcare transition. Let's move to the good news. First, children with chronic health conditions actually are now surviving to adulthood. Let me show you some of the figures. In the US, about 500,000 adolescents with special healthcare needs annually transfer to adult-focused care. In fact, if you look at congenital heart disease, about 800,000 adults in the US have congenital heart disease, and the majority of these patients are adults. Also, in cerebral palsy, for example, about 800,000 people have cerebral palsy, and about half of those are adults. So our patients are surviving, and they're becoming adults. So let me give you some figures. Published in the New England Journal of Medicine in '94, patients with sickle cell disease. In the 1970s, if you were diagnosed with this condition, your survival was in the mid-10s. But look at now in the years 2000s. You know, they can make it to older than 50 years of age. The same story goes for cystic fibrosis. In the 1950s, survival was horrendous. And now in the years 2000, patients with cystic fibrosis can make it to 40 years of age, particularly with the advent of lung transplants. When I started in this field, I wanted to learn how many patients in our adolescent age group survived to adult services and would come to your practices. And I learned that by dividing these folks, looking at the USRDS data, we learned that if you were diagnosed in the 1970s as a teenager as having end-stage kidney disease, you had about a 70% 10-year survival. But in the cohort that was diagnosed in the 1990s, what was available at that time, you had greater than 88% survival. And if you're a transplant patient, you have greater survival than if you're a dialysis patient. So that's the good news. Now the bad news. We started to talk about this field of healthcare transition in 1984. And in 1984, we decided that pediatric onset patients were transferring to adult-focused providers without the appropriate healthcare transition process. So transition is a process that starts really in your young teenage years and should prepare you to become an adult and should prepare you to self-manage your condition. What happens if you don't transition well, if you transfer to the adult services without a preparation? Well, we actually have evidence that if you're a transplant patient, you can actually reject your transplant. You're a greater likelihood to reject your transplant. Or if you're a diabetic patient, you have a higher hemoglobin A1C. Or if you're a patient with rheumatoid arthritis, you have a higher likelihood of having increased disease activity. So it seems to be bad news. Let me set the stage about what teenagers are like and what young adults are like in our days. This is an interesting slide that I downloaded a while ago, looking at age and psychosocial transition. And let me just show you how the red and blue, it's hard to read from the back, but how the red and blue sort of separate over time. And people are getting married at an older age. People are having houses at an older age. People are doing adult things at a much older age than biologically speaking. Just look around your children and your neighbors. This is a slide that I love to talk about to my internal medicine audience. And this is one nugget I would like to leave everyone with. So if I can just put this in your brain, this is an important slide. I think that when young adults come to your clinic, the most important question you need to ask is, how old were you when you were diagnosed? Because if you were an infant and a child when you were diagnosed with end-stage kidney disease, the likelihood is that you had a congenital anomaly. You obviously have had the disease longer. You had probably more urological procedures, probably more hospitalization, probably enuresis, right? You had less hypertension, less immune suppression, and less inflammation. But you are a child that, in fact, could have been diagnosed prenatally. So you have a set of parents that is very different from these parents. In fact, some of these children are not even born, and the parents are already mourning the fact that the child has a chronic or congenital anomaly of the kidney urinary tract. Whereas if you're an adolescent or a young adult, the likelihood of you having glomerular disease is greater. You've probably had the disease shorter, but you have seen more hypertension, more immune suppression, and probably more what we call inflammation. But I think that this separation is guiding some of our research, because I think that these children transfer or transition very differently from these young adults. This whole family interactions and dynamics are very, very different. So that's an important slide to remember. Let's move on to our 360-degree perspective on healthcare transition. We looked at transferred patients, patients who graduated from our program. We looked at parents' point of view, and we looked at health providers' point of views about transition. We thought that patients, internal medicine nephrologists, pediatric nephrologists, parents have this similar perception on transition. First of all, let me orient you as to the difference between a pediatric and internal medicine nephrology practice. Pediatric nephrologists are in academia for the most part. They have more access to resources. We have social workers, play therapy, psychologists. We are trained in congenital conditions. We're more familiar with adolescent development. And 40 to 60% of our census are these adolescents and young adults. Whereas if you look at the internal medicine practice, most of the internal medicine nephrologists are in private practice, have less access to the resources we do, and their census of young adults is about 2% of their practice. How do I know that? Well, I looked at USRDS data, but I also asked the GDC and collaborative internal medicine nephrologists that came to the 20th meeting. And 35 internal medicine nephrologists responding to the survey told me that in 95% of these practices, less than 2% of the patients are pediatric onset patients. So it's the minority of their census. They're also perceived as the healthiest. So they pay less attention, truly, to our patients because they don't have the COPD, the hypertension, the strokes, the heart attacks that the adults you guys enjoy and love taking care of. Thank goodness I don't. But they also told me that the pediatric onset patients seem less knowledgeable about their diagnosis and treatment, and they also consider that 45% of their patients are non-adherent compared to the adult onset patients. I'm going to pause for a second here, because if you look at the adult literature, half of the patients are non-adherent. All right? So here goes for my pediatric patients. I'm not sure why they're so upset with my kids when their adults are not as adherent as they should be. Fair is fair. So summarizing that information, they also told me that 75% of our patients came with an introduction. So that means that 25% of our patients don't even come with a phone call introducing these patients to their practices. They also told me that about 45% of their patients know their medicines, 30% of them know their condition. And also, more importantly, when they come to see them at clinic, they said that the patients themselves ask questions about 20% of the time. And more importantly, they came with parents, and the parents continue to ask the questions for the patients. Houston, we have a problem. I asked the Renal Physicians Association in an annual meeting when I was asked to come and talk similar questions. And there's not that much difference. These are people who responded to that survey. And in fact, these are nephrologists who've been in practice for a long time, most of them in private practice. They told me that they're about a mean of 24 miles from a pediatric nephrologist. They told me that about 1% of their patients are adolescents or young adults. And they told me that when they were training as fellows, they saw teens about 50% of the times. And why did they see teenagers? Because there were no access to a pediatric nephrologist. This is not news to a lot of us, but this is important. They also told me that the pediatricians, similar to the GDCN group, did not communicate about 30% of the times. But more importantly, when I asked them, okay, when the patient showed up to your practice, did you send the pediatrician a follow-up letter? And they also tell me that they only did that a quarter of the time. So here we are as pediatric nephrologists. We grow these children. We love them. We send them out to the adult world. And we don't know what's going on with them once they're in the adult world. So there's a lot of anxiety from more specialty about what happens to our patients. They also share with me that the major challenges to take care of transfer patients is adherence. They don't think that our patients become an adult successfully. They don't think they manage their disease successfully. Reimbursement to them is an issue because if they have no insurance, it's hard for them to see them. And they don't have access to multidisciplinary teams. So that's the internal medicine point of view. Let's go back to pediatric nephrologists. So I sent a 5-question email to a PEDNEP, which is an international listserv of pediatric nephrologists. 45% of people answer, and they told me in my questions, when I asked them, when do you start transition if your patient has chronic kidney disease? The USA, the mean age was 19 years of age. Forgive me, but that's a little late. The non-USA people actually at 18 years of age. If you look at the literature, transition should really start at about age 12. So nobody's doing it at an appropriate age. The similar answers for dialysis and transplant. But more importantly, I asked them, when do you start transition? 17 versus 16, although it is significant, it's not very different. More importantly, I asked them, do you have a transition program? And only 27% of the respondents said that they did in the US compared to 67% in other countries. I don't have time to go over the nuances of what happens internationally, but internationally, there is a lot of pressure to transition patients because if you're at a children's hospital, you cannot put kids that are older than 16 in your hospital. It just doesn't work. So that is in Canada and England and in other countries. So they have to do transition. So they're ahead of us in that sense. Let's talk about our patients. I sent a survey of graduates from our program 3 times with incentives, $10 to target if you answer this question, 3 times to 100 patients, and look at my response rate, which makes me worried about what happens to those who did not respond. But let's see what happens to those that responded. 70% are girls, mean age of 24, they're 18 to 41 years of age at this time. A pretty fair representation of our population. Half of them are transplant, and about 85% of them completed 12th grade. So these are people who have some education, perhaps had a good life. And look at their employment. Look at how many are married or have biological children. More importantly, look at their self-reported adherence. They say 45% of the times they're missed in medicines, and it was difficult to go to internal medicine care 40% of the time. So we have a lot of work to do. Lastly, let's talk about the parents' role in transition. So this is Victory Junction. For those of you who may not know, this is a camp for children with chronic illnesses. Your patients go to this camp. I have served them there. I sat in a parents focus group about transition. I actually sat in this focus group. Nobody knew I was a provider, okay? And some of my families were here. When we asked them what is the most important issue for transition, the answers by the parents from both groups are different. The heart and lung people are more worried about health insurance because they don't have the Medicare, Medicaid coverage that end stage has, right? for us was education, but very worrisome was treatment adherence for both groups. And what do I mean by that? So I was sitting in the room, and it was an eye-opener to me to see these parents compare notes and saying, oh, my kid misses medicines 3 days a week. Oh, mine sometimes 4 days a week. Ha, 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 ha. Right? I almost had a heart attack, because to me, that's the most important issue about a chronic illness, and to the parents, it didn't seem valuable. Granted, this is a small sample, but it was an eye-opener for me. Why is this an eye-opener? If you look at the transplant literature, 60% of kidney transplants report that parents are responsible for medicines, right? And Gerson described that if you have a parent with high distress, this is associated with non-adherence. So it's bad, and we need to work with the parents. So what did I learn in this 360-degree study? Is that pediatric nephrology practices transfer patients at an older age, have less transition programs compared to other countries. Transfer patients are less than 2% of their censuses and internal medicine practices. They seem less knowledgeable about their diagnosis and medications compared to adult-onset patients. 40% of transition patients believe they had a difficult transition, and parents play an important role in transition readiness and adherence to treatment. Okay, so I learned that we have a problem. So now I need to know, who do I serve? And I like this slide because it reminds me of what Ed Duran said. This is the man that was in charge of turning around Toyota when Toyota was successful and didn't have problems. But this man wrote, "In God we trust, everyone else bring data." This is a map that I know after talking to Dr. Chai and Dr. Hidalgo, we could duplicate in your practice. I took the address zip codes of my patients and plotted them in this program. Here we are. We're actually not exactly there, but I don't know how to draw a map in a different way. But these little dots represent the zip codes of the patients we serve. 45% of our patients have private insurance. My patients drive a mean number of 75 miles each way to come see me. And if the gas prices are higher, this no-show rate goes greater. We've measured literacy in our patients, and we've learned that about 40% of our parents are illiterate, and about 36% of our parents are single caregivers. I can't tell you about how important literacy and measurement of it is done in our institution. And in fact, now before I do dialysis training, we do literacy estimation so that we know how long we need to train the patients. That's another story. Let me move now to adolescence. When you're a teenager, you start to learn all of these skills. Well, some of us are still learning this one, but you start to learn all of these things as your brain starts to get populated. When we are in pediatric practices, we have to teach not only our patients, but also parents and grandparents. This is my family commercial, 30, 17, 11. My husband's taking the picture. But what we need to know as pediatricians is how are we going to teach these kids and how are we going to teach this parent when they all like to learn in different ways. Or teenagers like technology, or parents not necessarily. I say about age 25 and maturation to tell me about this important slide. Let me also tell you this information. This study is a study that was done in healthy human beings in California. Thousands of people in this sample. And they follow these people longitudinally. It's a 10-year study. And they looked at their brains by MRI. And look at how nicely the brain is populating as you age. And the brain forms from the occipital to the frontal area. Remind you, the frontal area of your brain is your CEO, the one that directs your abstract thinking, your logical thinking, etc. But you really are not fully equipped until you're about 25. Mind you, these are healthy people. So remember, when you have teenagers, they don't have all the equipment they need until they're about 25 years of age. A study that was done by Debbie Gibson, one of our partners, and one of our fellows, looked at memory and IQ with chronic kidney disease and correlated memory and IQ as if you have a greater GFR, you have better opportunity for memory, a better opportunity for IQ, whereas if you have a lower GFR, you have lower memory and IQ. Well, remember that brain MRI studies that I showed you? She also expanded her studies to do functional MRI in pediatric patients. This has not been published, so I'm sharing things. It's been published as an abstract only. So what they have been doing is they're doing functional MRIs and giving tasks to controls and to patients with chronic kidney disease. What I want to point out to you is, and I don't have time to go over the great detail, is look at all these lights that light up as patients are given tasks and memory things to do. All the lights are on, right? These are my patients with chronic kidney disease. It's like being in the dark. So this is your brain on CKD. So we're not only dealing with patients who have multiple conditions and comorbidities, but they have a great likelihood of having abnormal cognition. Interestingly, abnormal cognition is not only associated with chronic kidney disease, also it's associated with hypertension through the NHANES study that was done and published in 2004. Pre-hypertension also gives you abnormal condition, and diabetes gives you abnormal condition. All of those are comorbidities that our patients have. One more thing, I wanted to look at our population, and so I had the fortune of working with Jeremy So, and I asked him, look, you're a pediatric pharmacy, you're spending time with my families, I need you to, let's collect this data. And he said, yes, thank goodness. So of 283 patients that were seen in 8 months, we learned, this is in the pediatric nephrology practice, that the mean number of medicines is 5.7, but more importantly, in the red, the mean number of medicines for adolescents and young adults, it's 9. 9 medicines. If you're a transplant patient, you probably have 16 medications. Here's the worrisome part. In half of the visits of these patients during this study period, visits 1, 2, and 3, we changed their medicines 2 times per visit. So it's a moving target for our patients. So not only they're complex, they have cognition abnormalities, they have this big laundry list of medicines that we expect for them to memorize and know. These slides are just to remind me about the literacy studies that we've done and how it's different by race, but more importantly, the number of emergency room visits, if you have a lower literacy, is greater than if you have a higher literacy. And you're more likely to be less adherent with your medicines, less adherent with medical appointments, and less adherent with your diet if you have a lower literacy score. So transition is a process. And how do we get our patients from this age group to this age group? 1, without harming themselves, and 2, really being successful. Well, I had to think about transition in terms of not just having chronic kidney disease or a chronic condition, but really the goals of an emerging adult is to, one of those things is to survive. But if you survive, you would like to have some relationships, be employed, have an education, have mental health and housing. Well, this is the list for all of us, right? Transition really should begin the process at about 12 to 14 years of age by outlining responsibilities and encouraging the patients to be involved in their care. So really at about middle school, you need to start working with the patient, kick the parents out of the room, and start talking with patients alone. At 14 to 17 years of age, you start to practice more independence, and about age 18, you start to have them begin to take charge. This is a nice guideline, but that's when it starts. So when do we transfer our patients is the question that people always ask. Well, hopefully not at this age, but we really should transfer our patients when the patients are ready, and it needs to be personalized, and it needs to be flexible, and it needs to be really based on patients' cognition. So now we're moving to our program. It was funded in 2006. It was designed to teach, enhance, and measure skills of healthcare transition. It's designed to promote self-management, and we develop and are validating tools, and we continue to determine outcomes, both proximal and distal outcomes. I'm going to now talk about our 3 tools that we've invented, again, through interdisciplinary collaboration. The transition scale, transition readiness survey, and the transition passport. Our tools are web-based, and if you want to access them, and if you want to enter patient data, you can. It's HIPAA compliant. You would give your patient an ID number, and you would enter the ID number, but no other identifiers. No identifiers would be entered here. And I'm going to show you a bit what it looks like. I'm going to start with the transition scale. I'm very proud of this tool because we figured out that transition has 10 letters. So it became a 10-letter score, a 10-point score, really a 100% score later on. This one You have to ask the questions. It's, to me, the show me the money test. Self-report is wonderful, but it's like, no doctor, I don't have sex. Self-report is important because it's easy, but it's not necessarily accurate. So this is why I like this tool a whole lot. It's a really, you show me the skills, you get the points. It's web-based. It takes about 7.5 minutes. We've digitally recorded this. And with these digital recorders, we have verified that other people who listen to these recordings and rate the patients, there is a reliability kappa score of 70, which I'm told is a pretty decent score for reliability. It has 33 questions in global areas, and again, when the data is entered, it goes directly into the data bank. Based on this scale, we focus on transition skills based on age. So the 12 to 14-year-olds should know these skills. In fact, people argue that you could start transition at age 8, because if you know how to read, you should be able to read the name of your disease. We don't start at 12 because I only have one transition coordinator, and she can only do so much. But at age 15 and 18, we move on to other skills, and at older than 18, we move on to skills that are preparing the patient to migrate to the adult-focused care. Here's an example of our questions. This is Christy Bigford, our partner, has been around with us since the beginning, and she's an amazing woman who's done a lot of this work. She asks the patient, can you tell me the name of your health condition, the symptoms of your health condition, and how this condition may affect you in the future? Notice that it didn't ask, tell me the name of your kidney disease, because actually this tool is disease neutral. It can be used for any condition. Then R stands for RX, tell me the name of your medicine, and so forth and so on. When you enter the website, it reminds you of the different skills you have to learn by age group. And we also follow the stoplight system, and I'm going to show you what that means. This is what the questions look like, and of course it's hard to read from the back of the room, but all of these questions are answered a yes, somewhat, or no, and you will get a 0.5 or a 1 point if you get the answers correctly. When you submitted your answers, you immediately can print out a report, which you can hand to your patient and to the health provider. And this is what the report would look like, and this is the stoplight system that I was talking about. So if the patient is non-adherent and didn't answer the questions correctly, then they get a little red light. If they are getting there, they get a yellow light, and if they already know the skill, they get a green light. So I don't need to waste my time on teaching the patient things they already know. I love this scale because at the end it gives me a total score. It tells me the date, and I can follow this longitudinally. We give these scales every 6 months, but we are also learning that you can give it every year if you have no manpower, because the score really hasn't changed that much over time. We've recently completed an exploratory factor analysis, looking at what questions line up better. And we have learned that the most important questions, or the questions that line up the best, are these 12 questions. To us health providers, that's important. And I'm told that this alpha score of 0.79 is quite respectable for an exploratory factor analysis. So there is a possibility that we could shorten the transition scale to less questions, but we are still deliberating that, because even though some of the skills may not be necessarily lining up on exploratory factor analysis, you still need to know how to find new providers. You still need to know what your nutrition looks like. So far, so good? I asked pediatric nephrologists questions about the transition scale, and I asked them, how do I give much weight or less weight to the answers? And 52 people answered here. I also asked the RPA nephrologist that I talked a little while ago questions about this scale. And this is comparing the answers of the pediatricians versus the internal medicine nephrologists. They pretty much agree that the transfer patients or transitioning patients need to know their medications. Interestingly, there's a big divergence regarding adherence, but they're pretty close. And look at the difference between insurance coverage. Just not a disservice to my internal medicine colleagues, but it's a different focus from their standpoint. But the rest of the answers are pretty similar. So baseline transition score showed me when we first started that the 12-year-olds had a mean total score of 5.8. Remember, this is out of 10, and it's very similar to the 17-year-olds. These people are about to go to the internal medicine practices, and they don't know the answers correctly, so they're not prepared. This is what justifies our existence. I told you that this is a disease neutral scale, and I am also the director of the transition program at the UNC Children's Hospital, so now we collaborate with other divisions. And the GI folks, like the chronic kidney disease patients, also have low scores at any age, or lowish scores. I also wanted to look at transition scores based on age, and the 12 to 14-year-olds, the middle school age group patients, really don't vary very much, whereas the high school and the greater than 17-year-old patients all go up and gain skills at a greater rate. We have now created the transition scale parent version. I don't have much data to share with you today, and this has not been published. This is going to be presented in a couple of weeks. What we did is we expanded our transition scale for patients, and we moved it to parents. And it's the same number of questions. But when we were developing this, and I'm sorry this doesn't project very well, we were struggling to, how do we ask the question of the parent? And one of the things that moved us to do this parent version is that when Christy was sitting in a room asking the questions of the patient and the parent was around, the parent would go like, I don't know that. Or they would say, I didn't know you knew that. So it's pretty an eye-opener to the parents to hear their kids answer their questions or not answer their questions, or for the parents to realize that they themselves don't have the skill. So trying to decide, do we ask the parent, do you think your child knows the chronic condition? That's a perception question. I decided against it. I actually wanted to know if the parent knew the child's condition. I wanted to know if the parent really knew the kid's medicines, or if the parent understood the importance of insurance and why is it important to go to school. So we made these questions a parent knowledge questions, the ones in purple, whereas the ones in white is, do you think your child is adherent? Do you think your child can manage his disease? So here's what we're learning so far, fresh out of the oven. We have 39 patient-child dyads, and we have learned that the parent score is very similar to the adult score. This is somewhat of an eye-opener because you would think that the parent should have a 9 or 10. You would think that the parent should know the kid's medications and diagnosis, and truly it's an eye-opener for us. We have much work to do. We did learn that in terms of self-management and self-reported adherence, the parent and the child correlate very, very, very well. And we also, when we control for race, sex, and medical insurance, learned that the youth scores can predict the parent scores. We adjusted and put everybody in the same level, in the same playing field. If we adjust for percentage of life with the diagnosis, about 38, sorry, this should be about, and that's the median. And percentage of life with the disease predicted the parent scores. But here's the important finding. Parental scores negatively correlated with percentage of life, which is probably suggesting to us that those kids who are diagnosed early, we dedicate time, we educate them, we tell them your child has this, your child has that, but we don't reinforce that education later on. So we think that that knowledge goes away. We don't understand this finding. That's probably one of the explanations, but it is concerning to see that as the disease is longer, the parents do worse.
That's really surprising.
It is, and it's a small sample, but it's significant. We now have I'm Mexican, so of course I would have it in Spanish. We now have TRANSITION en español. We're collaborating with Puerto Rico, Colombia, and Mexico. I don't know where Salvador is. I don't know where Guillermo is, but we're going to start testing this scale in these countries or state. Now, let me move on to the self-reported transition readiness survey, what we call STARX. And this, like the other one, is web-based, but this one is self-administered. A number of questions from this survey match the transition scale questions. And it was developed with focus groups, focus interviews, cognitive interviews, and it measures self-activation, self-efficacy, and self-direction. It takes about 3 minutes to administer. This is what it looks like in the computer. It's 18 questions, and it says, for example, in the past 18 months, how often did you take your medicines on your own? Or how much do you know about your illness? Or how easy or hard is it to talk to your doctor? This test continues to be tested in several settings. Let me share some of the results we're learning so far. Girls do a little bit better, but not by much compared to boys in terms of these answers. And older patients do a little bit better than younger patients. The last tool I want to talk about is the Transition Passport. And it's a tool that provides communication between patients and providers in clinic or emergency rooms. It also serves as a patient education tool. It's easy access because it looks like a wallet size and is well accepted. This is what it looks like. So imagine this is your driver's license, and it fits in your wallet. It's laminated. It's homemade. This is my son, Ted Ferris, and the engine of this work. And so in the front, it has the name of the patient and emergency room things, and in the back, it has their diagnosis, allergies, and their medications. Let me spend a couple of moments about this. We not only put their medicines, how do they take them, but we also tell them why they take them. Why do they take these medicines? So it becomes a patient education tool. I have to tell you that our patients love this tool. Our adult partners want this tool for their adult patients. It is well accepted. I cannot tell you how many phone calls I get from emergency room physicians that say, your patient showed me their passport. This is fantastic. It was very easy for me to take care of your patient. Or portable medical record. The patients like it because it's not a bracelet. It doesn't make them look different. They don't want to be different. They don't want to look different. So they have it. So the acceptability is really great. One patient only has had a complaint about this passport because this young girl, somebody got into her purse and found it. And she was very upset because they learned about her medical condition. And that's the only difficulty we've had with the passport. Yes, ma'am. Yes. We update it. We do, and we used to update it at the transplant patients every month, but we've stopped doing that because on the fresh transplants, the medications change in the first 6 months. So we update them every 6 to 12 months, depending on when we see them. And we update them even if we don't see them in person. We also measure whether or not they have it. See this number over here? So we call them and we say, do you have your passport? And they say, of course I do. I have my passport. Okay, give me the second digit from the right. So we know how to deal with teenagers. They don't fool us that easily. Let me also tell you, comparing the IBD patients versus the chronic kidney disease patients, and there's a great difference by race and insurance, or patients with chronic kidney disease have more minorities and have more public insurance. But both groups keep their passport at about 9 to 12 months. So they have it 70% of the times. And in fact, our patients with chronic kidney disease, we had to revisit their passport more often than the GI patients. Okay? 6% of our patients with chronic kidney disease lost their passport, and none of the GI patients did. So we're very crazy and nuts about this tool. We think it's been very helpful in terms of not just transition, but disease self-management. So the successful transition patient at UNC is a patient who accesses health services independently, knows his diagnosis or her diagnosis and medications, carries their medical passports, knows health insurance options, and participates and contributes to social and community activities. Now, I had mentioned that there are short-term outcomes and long-term outcomes, or short-term outcomes or process outcomes include emergency room utilization, adherence to medications by prescription refill. So we call the pharmacists and have them fax us the last 6 months of their prescription refill. This is how I document non-adherence. Now, that doesn't tell me the patient didn't swallow it, but it at least tells me that the patient refilled the prescriptions. And there's a way to calculate, I don't have time to go over it, a medication prescription ratio, so that you know how adherent your patient is. If you're a transplant patient, you can actually understand whether or not they're adherent by looking at their progranulin or cyclosporin levels and looking at their standard deviations. And if you have more than 2 standard deviations, you're non-compliant or non-adherent. So there are ways for us to measure adherence. We also measure adherence with medical appointments. And those are the short-term or process outcomes. The long-term outcomes are obviously a patient who will succeed at going to the internal medicine practices and successfully self-manage their condition. Thank you for your attention. I discussed how adolescents with chronic health conditions survive to adult life. We talked about how all the players have a different perspective on transition. We discussed comorbidities and cognition and how it may affect transition. And lastly, we talked about transitions to measure, tools to measure transition, and I've shared some of our preliminary data. Thank you.